All right, let's talk about something you are going to see constantly in the clinic: the stuffy, runny, itchy nose. It seems simple, right? But behind that complaint is a really interesting diagnostic puzzle. So, for all of you trainees out there, we're going to walk through a clinical framework to help you nail the diagnosis every time. We're going to treat this just like a real clinical investigation. First up, we'll define the case. Then, we'll line up the usual suspects. After that, we'll broaden our search, keep an eye out for any dangerous mimics or red flags, and finally, put it all together into a solid plan. Okay, so let's start at the very beginning. Your patient walks in and they've got all the classic symptoms. They're sneezing, their nose is running, they feel all stuffed up. So what exactly is the diagnosis we're even talking about here? Well, the official definition of rhinitis is pretty straightforward. It's having one or more of these key symptoms: sneezing, that runny nose, which we call rhinorrhea, the classic stuffy feeling of nasal congestion, itching in the nose, and believe it or not, even a cough. And this right here is the big challenge. A patient has this cluster of symptoms, but the reason why could be anything from a simple pollen allergy to something much more complicated. So the question is, where on earth do you even begin? You always start with the most common culprits. And the very first, most important fork in the road is figuring out if you're dealing with allergic or non-allergic rhinitis. Getting this right is going to guide pretty much everything you do next. And allergic rhinitis is just incredibly common. I mean, look at this. It affects up to 40% of kids. So if your patient is a child with a runny nose, you have to have allergies right at the top of your list. And the great thing about kids with chronic allergies is they often give you these fantastic clues on the physical exam. You want to look for allergic shiners, that kind of bluish color under their eyes, and also look for a little line across their nose, a transverse nasal crease, from what we call the allergic salute, that constant upward wipe of the nose to scratch an itch. This chart is absolutely key. So let's break it down. Notice how allergic rhinitis usually kicks in when patients are younger, and the main thing they complain about is itching. Now compare that to non-allergic, which shows up later in life, and it's more about congestion and postnasal drip. The triggers are different too: allergens versus just general irritants. And here's a huge tip for your exam. Peek inside the nose. If it looks pale and swollen, think allergy. If it looks pretty much normal, lean towards non-allergic. But here's a real-world clinical pearl for you. It's not always so black and white. In fact, in adults, the most common diagnosis is what we call mixed rhinitis. This is where a patient has both types. They've got that non-allergic background, but then specific allergens come along and make everything way worse. Okay, so we've got the two big players down: allergic and non-allergic. Now it's time to broaden our horizons and think about some other really important causes that you're definitely going to see. Oh, this one is a classic trap: rhinitis medicamentosa. It's a problem caused by the treatment itself. The cycle is so predictable. A patient uses a decongestant spray. Feels great. Then it wears off, and the congestion comes roaring back, even worse than before. So what do? They use more spray, and they get stuck in this dependency loop. This is why you always have to ask, so what have you been using for your symptoms? And this is where being a good detective really pays off. Your history is everything. Ask about their job. Are things worse at work? Could be occupational rhinitis. Ask about pregnancy. Hormones can cause major congestion, especially near the end. And you have got to get a complete list of their medications. So many common drugs, from blood pressure meds to ED medication, can cause a stuffy nose. Even something as simple as a glass of wine can be the trigger. All right, let's switch gears to something incredibly important. Look, most rhinitis is totally benign, but you have to be on the lookout for the serious stuff that can pretend to be a simple stuffy nose. These are the red flags you absolutely cannot afford to miss. I want this to really sink in. Not all nasal obstruction is rhinitis. When a patient says, "My nose is blocked," your brain has to go beyond just inflammation. You have to start thinking about structural problems and other serious causes. And here it is, the single biggest red flag: unilateral symptoms. Think about it. Allergies, viruses, irritants, they don't just pick one nostril. Rhinitis is almost always a two-sided problem. So if your patient complains about blockage or discharge on only one side, your alarm bells need to be ringing loud and clear. So why is this such a big deal? Because one-sided symptoms mean you have to start thinking about much more serious things. Sure, it could be a deviated septum, but you absolutely have to rule out the scary stuff, like a nasal tumor or even a leak of cerebral spinal fluid. So you've taken a great history, you've done your exam, you've got your list of possible causes. What now? What's the plan? A huge part of that, especially as a trainee, is knowing when you can handle it and when it's time to call for help.
Knowing who to call is pretty straightforward. If you're pretty sure it's allergies but your initial treatments aren't working or you need specific testing, that's a referral to allergy/immunology. But if you see any of those red flags we just talked about, one-sided symptoms, a history of trauma, or you're worried about a structural problem like a tumor or a CSF leak, that's an immediate referral to ENT.
And there you have it. That's our clinical framework. We went all the way from a basic definition to the big red flags and when to refer. So the next time a patient walks in complaining about a stuffy nose, you'll know what to do. What's the first question you're going to ask?